Hello and good evening to you all. Thank you for joining us again tonight. This is our second event. This time we are having IVF webinar and of course yet another topic to discuss, yet another special guest with us to help you out a bit. And of course, as always, let me remind you that we are here to support you every single day from Monday to Friday so that you can find out some more details on IVF treatment or on options and also meet top fertility experts. And as always, I am your host, Caroline. And please let us know that you can hear us and very clearly. And of course, thank you to our partners and ambassadors as always for joining our initiative, for supporting our initiative Stronger Together. As you know, it would not be possible to have so many of those events without the help of those ambassadors and partners. And well, tonight, as I've mentioned, we do have another interesting topic to discuss for sure. And the topic is how repeated stimulation influences the number of oocytes obtained in a consecutive cycle. And with us tonight, we have Dr. Yuliya Blazhko. She is a fertility specialist, obstetrician, gynecologist at Grishenko Clinic IVF, which is located in Ukraine. So, hello to Ukraine. Hello, Dr. Yuliya. How are you feeling tonight? We are happy to have you here with us tonight.
Hello, Caroline. Excellent. It's good to be with you. Greetings from Ukraine.
Perfect. Thank you so much. And let me just remind everyone that we will start with the presentation from Dr. Yuliya, and she will be happy to explain all the details. And of course, after that, it will be time for your questions. As you know, all you need to do is just type in the questions in the chat section. And after the presentation, we will be presenting them one by one so that Dr. Yuliya can answer them for you. So don't miss this opportunity and ask your questions and get some advice, some recommendations as well. And for now, this is it from me. And of course, Dr. Yuliya can start with your presentation. Are you ready?
Yes, I am.
Excellent. Thank you so much. Go ahead then.
Good evening to all of you. Thank you, Caroline, for your introduction. Just a couple of words about myself. I'm a fertility specialist. I work at Clinic since 2008, and since 2012, I provide an IVF procedures. Our clinic is the first clinic that started IVF in Ukraine, and in 1991, the first IVF cycle was provided under the supervision of our founder, academician Grishenko. And tonight I'm pleased to be talking to you and about how repeated controlled ovarian stimulation influences the number of oocytes obtained in a consecutive cycle. My patients who undergo several controlled ovarian stimulation often ask me this question. This is why I decided to give it an answer to all of you. So I should say that this option is allowed not everywhere. First of all, because of law and ethical limitations. So commercial outside donation is able in Barbados, Czech Republic, Cyprus, Greece, India, Mexico, such countries as Panama, Russia, Spain, South Africa, USA, UK, and Ukraine as well. Altruistic donation without payment is able to provide in Australia, France, and Canada, and in other countries, any type of donation is forbidden. So patients who can't possibly undergo an IVF cycle with donors outside in their home countries often go to other countries and to our clinic as well. So what are requirements for donors controlled ovarian stimulation? First of all, it has to be effective by the number of oocytes and their quality. For sure, it has to be safe. We must avoid any complications or whether complications during controlled ovarian stimulation as the complications that can become later, further complications. And of course, it can be economically profitable, so maximal effectiveness and without any complications. So according to these criteria, patients with normal or hyperresponse to controlled ovarian stimulation meet the same requirements as the oocyte donors. So we decided to make an analysis of oocyte donor stimulations and extrapolate these data for the stimulations of patients. First, about scheduling or about several ways to realize the programs with donor oocytes. In first case, we can use fresh donor oocytes to fertilize them by their partners or donor sperm, and then to transfer it into the uterus of patient without vitrification. But in this case, synchronization of the donors and patient cycle is required, and this is not always convenient because we can lose egg quality or oocyte quality. This is why that is not the best way of oocyte donors programs. In the second case, we can use donor oocytes, which fertilize them, and then transfer in artificial or natural cycle of recipient. And in the third case, we can get fresh donor eggs, fertilize them, and then vitrificate the embryos and further transfer them in artificial or natural cycle of the recipient. Of course, vitrification makes our protocols more convenient and flexible for patients, and using of vitrification technologies gives us the possibility to provide implantational genetical testing as well. Just several ways to synchronize the cycles of the donor or recipient. Shortly about them, we can use oral contraceptive pills. One protocol generates antagonists, estradiol, and progesterone. In this slide, I have presented the data of meta-analysis that shows that using of oral contraceptive pills can influence the final outcome of the IVF procedures, such as pregnancy outcome, and their probability of an ongoing pregnancy can be significantly lower in patients who received oral contraceptive pills treatment. Though the definite reason is still unclear, theoretically it can be because of negative impact on endometrial receptivity. But in case we use vitrification of oocytes or embryos, this is not so significant, and of course we can use this tool for synchronization. In case we use generate antagonists for scheduling, we start administer them before the gonadotropins to postpone the stimulation launch. And as we can see, of course, this makes the stimulation a little bit longer and somewhat more expensive, but it does not influence the final outcome and does not influence any embryological characteristics or ongoing pregnancy rate. Using estradiol for scheduling is also a very convenient tool because we start administer estradiol before the start of the cycle, and there is a scheme in which we can regulate the day of oocyte retrieval depending on a day's number of days that estradiol is administered. And in this case, this scan is very convenient both for patients and staff work organization, and it's always easier to make some plans and to mm, optimize the IVF cycle and IVF procedures. And as we can see from these data, using estradiol for pretreatment led us to get a bigger number of mature follicles and a bigger number of available embryos, but it does not influences the final outcome just like a clinical pregnancy rate. And what about mature follicles and available embryos? Maybe this happens because of suppressing of preterm rise of FSH and coordination of follicle growth and follicle pool alignment. So this is quite good tool for scheduling. Talking about types of stimulation protocols, there are a lot of stimulation protocols that we know. We know about 19 types of them. And here you can see the most used. Of course, the most used protocols are the LOM protocol and antagonist protocol as well. In our clinic, we don't use LOM protocol at the moment. Initially, we did so, but there is a convincing data that shows then using such type of protocol can lead us to complications during ovarian stimulation, and we can see that using generate antagonist protocol with ACG triggering or a generate antagonist protocol with ACG triggering, we can get complications such as hyperstimulation syndrome. But in case we use generate antagonist protocol with generate agonist triggering, we will not have any complications after the stimulation. So using this data, we changed our strategy of the stimulation of donors. As you can see, since 212, we reduced using LOM protocol, and since 215, we don't use LOM protocol at all. And this let us avoid ovarian hyperstimulation syndrome. So since 215, we don't have such a complication at all. Here you can see the guidance for clinicians where there is a cutoff level of IMH, and that is about 3 and 36 nanogram per milliliter, and this is a risk factor of ovarian hyperstimulation syndrome. Usually donors have AMH level close to this or even higher, and of course patients who have such big MH level will guide them to be hyper responders to controlled ovarian stimulation. And of course, we try to optimize the controlled ovarian stimulation and to avoid any complications. Here you can see the screen of our program, of our software, and there are several controlled ovarian stimulations, repeated controlled ovarian stimulations. As you can see, it was 6 of them, and a patient who had initial level of her AMH hormone 1 and 1 nanogram per milliliter, and we regard her as to be a normal responder. She could be as a low responder when we get 4 oocytes at one stimulation, and she also used to be a hyper responder when we get more than 20 oocytes in the next cycle. So expected normal responder can become as well as poor responder, as hyper responder. And in this case, a very likely hyperresponder with AMH level 12 and 6 nanogram per milliliter could be even a poor responder when we get 5 oocytes, and she was a hyperresponder as well when we get 35 oocytes. And I should say that every time we used very similar stimulation protocols with the same FSH dosage and the same start day of administration of follicular stimulation hormones, but the outcome and the result was not the same every time. And this is what this study shows, and what we can see here, that there is a data and there is effect of intracycle or intra-individual variability when a normal responder can become a poor responder or hyper-responder in 19% cases. And from the other way, a poor responder can become a hyper responder or normal responder in 39% of cases. So the answer on the controlled stimulation is not always predictable, even at the same patients with the same hormonal level and with the same stimulation protocols. Of course, this is very important how many oocytes will we get because in different age groups it can be a predictable factor of a live birth. And our goal is not pregnancy, not to just to get pregnant. Our goal is live birth. That's why we always aim to reach this one goal. And as you can see, there is a difference to get 5 oocytes in the age from 18 to 34 and have a predicted live birth at about 30%, whether to obtain 5 oocytes in the age 40 years and over and get a predicted live birth less than 10%. There is a conclusion of the Committee of the American Society for Reproductive Medicine about repetitive oocyte donation, and we can see that, of course, donors are exposed to the risk of controlled ovarian stimulation, oocyte retrieval, and anesthesia, and of course, the risk of ovarian hyperstimulation syndrome occurs to be 1 or 2%, but still this data doesn't show any and doesn't demonstrate any significant risk of future cancer. That's why we provide repetitive ovarian stimulation. And also, we don't see any decreasing of AMH level or number of oocytes retrieved from one stimulation to another. And this data shows 6 cycles of repetitive stimulation, and it does not show any significant difference between AMH level or oocytes retrieved. There is one more study about the number of oocytes and effect of controlled stimulation in donors and this result does not reveal any significant difference in number of oocytes obtained in a consecutive cycle. We compared these studies to our data and concluded that Ovary reserve does not decrease with the number of stimulations, and we compared several stimulations at donor of oocytes, and we didn't see any decreasing of the number of oocytes that we get. So talking about results, we definitely can say that controlled ovarian stimulation protocols with antagonists for donors that are normal and hyper responders is a protocol of choice. We also can say that intracycle variability of the follicle pool is a factor which influences the numerical results of stimulation with practically identical controlled ovarian stimulation schemes. And as a result, that repeated controlled ovarian stimulations do not demonstrate negative dynamics in terms of a decreased number of oocytes or diminished ovarian reserve in following stimulation cycles. And of course, I would like to thank you for your attention and to wish to all of you the best outcomes of ovarian stimulation of your IVF procedures. Of course, I want to wish to all of you healthy pregnancies and as a result to see a new baby smile.
And thank you so much, Dr. Yuliya, for your presentation. Lots of interesting details on our topic today. And thank you for providing all of them for us. And now, as you already know, we will go for our patients' questions. So my question is, are you ready for them?
I'll try to do my best. I hope I am.
Excellent. Thank you so much. And of course, we do have some of the questions ready. So let me start with the first one. I'm doing egg donation with fresh eggs. My donor has donated 4 times. I will be her fifth, 3 confirmed pregnancy from 4 of her previous donations. Is this going to affect her eggs quality that it will be her fifth time?
Well, thank you for your question. This is a very interesting question. As I have already mentioned, we don't see any bad influences of the repetitive ovarian stimulations. And the fact that she confirmed pregnancies from 4 of her previous donations is a good predictive factor that her oocytes have a good quality. That's why it seems to me that it will be no bad effect, and the fifth time he will show the same good results that she showed before.
All right.
Caroline, I don't hear you.
All right. Can you hear me now?
Yes.
Okay, apologies. I'm right here, of course. In case of using donor's eggs in IVF, do you usually recommend having embryos PGD tested or not? What is the regular procedure?
Well, PGTA procedure is widely implemented in our clinic, and in spite of donors have a rather low risk of genetical abnormalities of embryos, they still have a risk. The risk is about approximately 30 or 40%, um, but this technology led us to determine normal embryo faster and to avoid implantation failures or to minimize the risk of miscarriage.
Okay, perfect. Thank you so much for your question, as well as your answer to that. And well, there is one more question here. Is this only relevant for donors eggs? Because I have low ovarian reserve and low AMH, and previous ICSI has been with high dose stims, but I am thinking of doing milder stims and then batch cycling, Yes, of 3 cycles to harvest as many eggs as I can, then do a frozen transfer. That way, I would hope we would have possible sibling option also, and this will be our fourth ICSI cycle, so think we need to change protocol as not worked previously.
No, of course, these data are relevant not only for donors' eggs. I've mentioned it that we decided to compare this result with patient simulations, but I have to say that AMH level and ovarian resolve just decreases with age, and it's not connected with repeated ovarian stimulation. Just every year, the oocyte quantity becomes lower. That is why if you provide several stimulations from year to year, this is quite predictable that in 4 years you will get less oocyte quantity than, for example, at first stimulation.
All right, excellent. Thank you for again for your question and of course your answer to that. More questions are coming. Next one is right here as well. From my own ex, and I used to get 5 usually, and it created more less, I think, 3 embryos. How many can I expect from 28-year-old donor? How many eggs and how many embryos on average? My doctor said it is usually 10, 15 eggs and 2 good embryos. I find it hard to imagine because with my first 5 bad quality eggs, I used to get 3 embryos B quality, so I think it should be much more from a donor.
Yes, actually, I agree with you that two good embryos for 10 or even 15 eggs is very, very poor quantity, especially if donor is 28 years old. Her egg quality might be good enough, and her blastulation level have to be at least 15 or 50 or 60%. That's why 50 or 60% of 10 or 15 eggs is, of course, more than two good embryos. So I'm
All
agree
right.
with you that you might wait for more quantity of embryos.
Okay, excellent. Thank you for this as well. Okay, and should the egg donors who will now start their cycles have to be tested for COVID before they start?
Thank you for this very actual question. Of course, they have to, and this is actually what European Association of Reproductive Medicine tells that, of course, patients have to be tested and egg donors as well because there is a risk to um, manifest your coronavirus during the stimulation, and there is a risk for um, inflammation of staff and other patients, and a risk of canceling of the procedure because that is why I think this is necessary investigation nowadays.
Of course, definitely, yes. We all need to make sure that it's okay to go ahead as well. Perfect. Thank you so much. And next question is ready here. Good evening. I had 2 IVF attempts with own eggs. One failed, and I had a miscarriage. What would you recommend? Me, should I try with own eggs again or with donor eggs? I am 40.
Mhm. Thank you for your question. Of course, I would advise you not to give up anyway and to continue your journey to the motherhood. I should say that you can try with your ex as long as you can, but understanding that the chances of pregnancy are reduced with age, of course, and at the age about 40 years, the chance for live birth is up to 10%. And using donor eggs, your chances increase up to 60 or 70%. This is why, of course, if you will try, of course, I will advise you to provide genetical testing of embryos, but still you have both variants.
All right, excellent. Thank you so much once again for that question as well as your advice on this. Okay, someone is typing. I just want to check. Okay. Okay, let's. This is another question, so no problem. Let me go to the next question. This is quite a longer question, okay? So let's have a look at this. I will potentially be using a donor that is 22 and she has a healthy child of her own. She has donated twice before each time, resulting in around 10 to 1920 eggs and 7 out of 10 embryos after PGD. They are euploid. Her last cycle was January 2020. This time with us will be her third. What sort of outcome we could expect with her, what sort of prenatal vitamins, etc., would be important for her to take, how can we maximize a good outcome with good quality eggs and embryos.
Thank you for your question. Well, her outcome at her previous stimulation was rather good, from um, 19 to 20 eggs, and euploid rate was also very good, and her age actually is very perspective. That is why it seems to me that mm, at the third time her outcome will be not less, will be this as good as it was already. Uh, and what about vitamins? Of course, we advise to use folio, folic acid, as a dosage 0 and 8 milligrams per day. And nowadays we all have an insufficiency of vitamin D3. That is why it will be useful to make an analysis of this vitamin, and in case she has an insufficiency, she also can use this vitamin. And what about outcome and maximizing the outcome? This might be a question to your doctors and your clinic. We guarantee to our patients a definite number of oocytes. And if donor gets less oocytes, we can defreeze oocytes that we have in our bank and to uh, provide the necessary quantity of the oocytes to the patient.
All right, excellent. Thank you so
Uh,
much for that, of course, as well. And now let me have a look. Of course, we do have more questions coming up here. So next one is okay, here. Which day is the best day to do all the tests for the donor? Day 3? Do the results change between day 1 to day 5?
I would like to know what test do you mean? All
Yes,
the
if you
tests,
can.
what lab tests, or what
AMH,
exactly do
LH,
you mean?
etc.
AMH, LH, etc. Thank you. Um, AMH level does not depend of the day of the cycle, and LH level is necessary to know closer to day of oocyte retrieval, but initially we determine the LH level day 3 or day 4. Actually, every day between day 1 and day 5 is good day to determine these hormones.
And what about uterine scan?
Uh, it seems to me that you mean uterine skin or follicles or ovary skin, because of course it matters just general gynecological health. But yes, uh, we provide and I would suggest to make uterus and ovary scan at the beginning of the cycle to have good visualization of antral follicles and to have an antral follicle count. So it's the good days are also the beginning of the cycle.
Okay, thank you for that. And there is a follow-up question in regards to the previous question, okay, when it comes to those vitamins, or is it this just the recipient that needs to take folic and vitamins?
Both donor and recipient needs to take folic and vitamins because um, both matters, and oocyte quality and the factors that influences the pregnancy.
Of course. Thank you for clarification to this question as well. Okay, next question is up. I'm 28. With 27, I froze my eggs for social reasons. I got restricted 16 eggs, but only 10. I'm not sure. Sorry. Is this number low? Would you expect more mature eggs from those 16? Thanks.
Thank you for your question. Um, no, it seems to me that this number is quite normal. Um, Actually, we expect a good answer to controlled ovarian stimulation when we get from 8 to 15 or 16 oocytes. That's why 10 major oocytes is uh, a good result. Um, I don't think that after sowing you will get more than 16 major eggs. Actually, more than 10 major eggs, because at the moment of freezing, it was 10 major eggs.
All
But
right.
10 eggs is still a good quantity.
Of course. Excellent. Thank you so much for that clarification as well and your question indeed. Okay, next question is here. I'm thinking of doing 2 cycles in a row, one climate cycle with freezing on embryos and then one normal stimulation cycle with gonal F and menopause straight after. What are your thoughts on this?
I'm a little bit confused about the question, or what actually is the question. Two stimulation is okay. If embryos were freezed, it's okay. And what about outcome of the second stimulation?
If you could clarify that for us so we can make sure and answer properly, okay? Okay, I guess we can just wait for the patient to type some additional information, okay? Because it's like one cycle and then straight after another one. Not sure. So please let us know what you mean exactly so we can answer. And now we will go to the next question and we can always go back to this one as well. Okay?
Yes, of course.
Okay, perfect. Thank you. All right. Are the egg donors told by doctors to use folic acid and vitamins before they donate? Do you think me as a recipient can request from the clinic to ask that anonymous lady for that?
We in our clinic usually recommend to our donors to use vitamins before they donate. If you can request it, it seems to me that it depends on a clinic, but actually they can give you full information about preparation of donors, and this is not a secret. That's why it seems to me that it won't be any problem to request the clinic what medications and what preparations they provide to the donor.
All right, excellent. Thank you so much again for your question as well as your answer. There is one more question left. So I encourage anyone, if you have any questions, go ahead and type those in. If not, we will be finishing. So don't miss your chance and ask your questions so that Yuliya can help you out a bit as well. Okay, and so the question is here. Okay, there are 3 parts of that. Uh, okay, sorry. I am from Indonesia. and it's not legal here. Is it possible if I got to your clinic with my donor and then came back to my country after the process? Is that possible?
This calls an individual donation program, so you can provide your um, individual donor. We can make a stimulation for her, and then to fertilize donor eggs and to make an embryo transfer to your uterus. Do you mean this process? If it is so, I think this is quite possible, and
Okay.
we will be able to do this.
Okay, thank you for your question. And the second part is, and how long that the process would take from the same patient,
Um,
of course.
This process can take from 1 to 2 or 3 months. We have to get oocytes. It will take about 2 weeks, and then the further plans depend on actually your plans. We can freeze them at the moment and to provide a genetical testing, and then to put it back to the uterus at the second cycle. Or without genetical testing, we can do it just in the second cycle. So on average, it takes about 1 or 2 or 3 months.
All right, thank you so much for clarification once again. And next question is, at least for now, it is our last one. Does your clinic do guarantee live birth packages?
We don't like this word guarantee because this procedure has not 100% of success. That is why to guarantee something is not very truly. And usually all those guarantee programs are concluding several IVF attempts, and the price and the cost of these guarantee programs are 3 times higher than just usual IVF program. Um, that's why at the moment we don't have such a program, but maybe in future we will provide such a program.
Of course, thank you for your question as well as your assistance with this and answer, of course. Okay, I'm just checking if there are some questions. If not, we will be finishing. So I just want to make sure you have asked all of your questions. Okay, let's wait a minute. And well, in the meantime, Dr. Yuliya, is there anything you would like to add?
I would like to thank you one more time for your questions and for your attention. And I would like to say that we're always happy to answer all your questions at the private messages and by email. You're always welcome to ask whatever you want, and we will be in touch and try to clarify everything you want.
Excellent. Thank you so much for that. And of course, I just want to mention to everyone that if you would like to ask Dr. Yulia and her team any details, more details, you can also use this link I have just sent to you. And there is an option to ask your questions. And it will be, of course, forwarded straight away to the clinic and, of course, Dr. Yulia. And well, I guess that will be it for today. We are having a comment. I mean, thank you from the patient. First one right here. Thank you very much for the presentation and answers. And someone is typing, so I
Thank
believe it's
you.
also a thank you. But I just want to make sure. Uh, Thank you so much, Dr. Yulia, for joining our Stronger Together initiative, for your time. I know it's quite late in Ukraine, so thank you for joining us on such a late evening Friday, in fact. So it's a pleasure to have you with us, and thank you for your as well presentation and all the answers you have provided to our patients. I'm sure it has been useful, and to all of you, thank you all again for joining us today, but also for joining us every single day. As you know, there are more of those events coming up. Next week, we will start again at 6 p.m., at 8 p.m., right after this. So I do hope you will be able to join us as well. And you can find all those webinars, all those online patient meetings on our website, myivfanswers.com. And of course, this one has been recorded and you will find it there as well. And I can only encourage you to follow us on our Facebook page and just Instagram. And that way you will know when the new events are coming up. And yes, I can see, okay, legal webinar on egg donors and surrogacy. Okay, noted. I always note that. I know there is a surrogacy um, actually in the US coming up, at least for now. Nothing else at this point, but I always note that. Okay, Angela, thank you so much for that suggestion. And of course, just let me remind you that if you have any suggestions, you can definitely email us. You can send us this, and we will be happy to look at it and then check if we can do something about that. We are more than open to your suggestions as well. Thank you so much, Dr. Yuliya, again, and
Thank you,
have a
Caroline, and to your help, to your team.
perfect. Thank you so much. And also, everyone, have a lovely weekend. And I hope you will have a relaxing time as well. I hope to see you back here on Monday. Take care. And Dr. Yulia, once again, thank you and good night.
Thank you. I hope we'll see once again. Once.
Exactly. Hope we can do it as well. Thank you so much. Bye.
Bye.